Good evening, and thank you all for coming out. I'm Dr. Daniel Southern, and we're doing a talk tonight on a new field of medicine. Basically, what we're going to do is discuss what that new field is, compare how it differs to traditional medical treatments for arthritis and joint pain. Then we're going to discuss who's a good candidate for these procedures that I do in my office. And finally, we're going to review some of the literature on how this stuff works. So that's the goal of this evening. I have 50 slides, so this is going to be the better part of an hour. Some of them will go by very fast. Others we're going to be talking about a little bit longer. I'm happy to stay afterwards as long as anyone has any questions whatsoever. And uh, honestly, there are no dumb questions. Please. Um, Type into the chat box there, and I will happily answer all of your questions for as long as you keep typing them in. All right, let's get started. The title of tonight's discussion is, Does your joint pain really need surgery? In 2005, physicians in the United States, for the first time on Earth, began treating orthopedic conditions using precise human repair cell injections. The case study that started it all was by Centeno in 2006. He published the results of treating a 64-year-old male with a 20-year history of hip pain with very advanced hip arthritis. What he did was he went into the man's bone marrow, got some bone marrow, concentrated it down, and injected it into the hip. He did this twice, 4 weeks apart. He did it a second time. He cultured the stem cells that he got from the bone marrow of this patient. So he put in quite a few 100,000 stem cells, autologous stem cells. Autologous is a fancy word for self. And this is the picture of the MRI he studied. On top is before. This large dark thing with some white in it is the head of it's the ball of the ball joint of the hip, and this is the cup. And there is no space between them, as you see. And he published this study. It's an after study, and you can now see a space between the cup and the ball joint. And there is a line of cortical bone that is brand new and was laid down. This was eye-opening, and this got a lot of attention. And this heralded a new medical specialty, and that medical specialty goes by the name. It's a subset of orthopedic treatment. It's known as interventional orthopedics. Well, what the heck is interventional orthopedics? Well, let's compare it to traditional orthopedics. Everybody knows what an orthopedic is. He's a doc who treats joints and joint pain, neck and back pain. And he's a surgeon. Don't forget that. In traditional orthopedics, the doctor is using scalpel, drills, saws to incise, cut, grind, amputate, and place screws, plates, rods, nails, anchors, staples, and sutures. The metaphor here is one of carpentry, as opposed to interventional, or otherwise known as regenerative orthopedics. We are using only needles, and very advanced imaging, which includes ultrasound and fluoroscopy, which is real-time X-ray. What we're doing is we're injecting. What are we injecting? We're injecting our patient's own blood and or cells. We are planting seeds. We're hoping to deliver growth factors to damaged tissues to help them grow. The metaphor here is gardening. Carpentry, gardening. In traditional orthopedics, the surgeon is removing and rearranging tissue. He is deconstructing and reconstructing tissues. He is replacing native structures. In interventional regenerative orthopedics, we are attempting to repair and regrow tissue. We are trying to preserve native structures. Why is that important? Well, the human body, the design of which has been refined over many, many, many thousands of years. That design has grown and changed according to the demands of the human body. For the most part, I would say 99.8 or 9%. The design is approaching perfection. The point being, if you alter that design, no matter what you get from the alteration that you are performing, it comes at a cost. You're going to pay for that. The take-home message is it is always, always, always better, if possible, to preserve the native structure and the native tissues of the human body. And that's what we're trying to do in interventional orthopedics. Let's discuss the traditional orthopedic treatment. It starts with pain. In this algorithm here that I'm showing, it starts is an injury. Let's assume that maybe you banged yourself, or maybe you just suddenly develop pain in the joint or your back or your neck, and you go, man, that really hurts. Well, what do you do? Well, like all of us, you go to the medicine cabinet, you take a couple of ibuprofen. If it's really bad, you put some ice on it, you elevate it because you've been told that what you do when you got pain. And for the most part, it'll get better, right? If it doesn't, maybe you walk into a physical therapist's office. And the physical therapist treats you for a while. And working with a professional, that often makes a difference and people are fine. But if you're not, you end up calling the GP, getting an appointment, going in, and he throws up his hands and goes, you're talking joint pain. I don't know anything about that. Go see the orthopedic. So you go to the orthopedic's office and he says, oh, so you've tried ibuprofen and rest and a little physical therapy and it's not working for you? Let's do a steroid injection. So he'll inject the joint or your neck or your back. And quite often that makes things better, at least for a little while. But let's say the pain then comes back or the injection didn't work and you go back to the orthopedic and he says, well, time for an MRI. Well, let me tell you something. If you're standing in a surgeon's office and you're looking at an MRI together, what do you think your chances for surgery are? They go up about 90%. Now, surgery, insofar as it alters the native tissues, can accelerate the degeneration of whatever structure has been treated over time. And surgery tends to lead to more surgery. And a few years go by and you're back in the orthopedics office saying, you know what? The knee still is killing me, doc. And he looks at you and he says, well, the only thing I got for you is joint replacement. This is the standard algorithm of treatment in any orthopedics office to this day, anywhere in this country. What's wrong with it? Well, let's start with steroid injections. We learned long ago as doctors that steroids are quite remarkable. And if you inject a painful joint with steroids, patients often think that you're a miracle worker because they feel so much better. Unfortunately, we as doctors now know that effect is very transient. It doesn't last, and in the long run, doesn't really change much of anything. Steroids are bad for you, no matter how you cut it. In the long run, they're bad. A single joint injection here or there is okay. But repeated injections are bad for you. Now, in the old days, when I first started training, the rule was you injected a joint with steroid only 3 times in the lifetime of that joint. And that was based on the fact that we knew that if you injected a joint with steroids repeatedly, the bad things such as spontaneous rupture of ligaments that hold the joint together would begin to occur, which we attributed to steroid injection. So it was like, okay, we need to limit this. But over time, that got fudged. And orthopedics now are still in the habit of injecting a joint repeatedly with steroids. As long as you come in and you're too young for a joint replacement, they'll keep injecting it with steroids. Well, there was a study done in 2017 in the Journal of American Medical Association, a very reputable journal. And what they did was they randomized patient. What that means is they signed up a bunch of patients and just arbitrarily assigned some to a treatment group and the other to a control group. Well, the treatment group got a steroid, triamcinolone acetate, 40 milligrams, injected into their painful knee every 3 months for 2 years. The control group got an injection of water, sterile water, into their knee every 3 months for 2 years. They got MRIs of the knees they were treating before and after 2 years of treatment. What do you think they found at the end of 2 years? In the joints that had been injected every 3 months with steroids, that's a total of 8 steroid injections. At the end of 2 years, the MRI showed a 50% loss of cartilage. That's right, 50%. Why? Because steroids kills anything it comes in contact with. That's why. So in other words, steroids was killing the very cells that we're trying to keep healthy in a joint that's becoming painful. It was killing chondrocytes and cartilage. It was killing fibrocytes and ligaments. It was killing tenocytes and tendons. In addition to that, steroids weakens your ligaments. It lowers your bone density. It raises your blood sugar. It suppresses the immune system, making you more susceptible to infection. It suppresses your adrenocortical axis. It causes weakness, fatigue, and depression. And this is not to mention what steroids are routinely injected with, local anesthetics. These drugs, bupivacaine and lidocaine in particular, are even more toxic than steroids. So in the long run, if you're repeatedly injecting a joint that's painful with steroids, you're doing yourself a disservice because you are rapidly killing the joint. What's wrong with the current algorithm, meniscectomy? This is the famous, oh, let's clean up that arthritis in your joint procedure. It's an arthroscopic procedure as pictured here. It's minimally invasive. But what they are typically doing when they are saying they are cleaning up, they are cutting out tissue. They are removing big hunks of cartilage known as the meniscus in the knee, for example. That's what a meniscectomy is, so that you can't see the tear that they're seeing on MRI any longer. And that's because they've removed the portion that's torn. The bad news is that this procedure has been shown without a doubt to be contraindicated. Why? Because people who have this procedure have a 3-time increased risk after 8 years of osteoarthritis in their joint. Why? Well, it only makes sense. If you're removing the tissues that cushion the loading of the joint, what you're doing is you're increasing the loading forces. If you increase loading forces over time, what you're doing is you're rapidly accelerating the degeneration of that joint. So this is a procedure that shouldn't be done. Period. End of story. Shouldn't be done. Is it still being done? You bet. Every day across this country. What's wrong with the current algorithm? Knee ligament repair, referring specifically to the traditional ACL repair, the anterior cruciate ligament in the knee. This is a procedure that is really quite wonderful, and orthopedics are rightfully very proud of it. Why? Because this procedure gets professional athletes back on the playing field. If you have torn your ACL, you cannot play professional sports. Full stop. Can't do it. The knee is unstable front and back. You just slip the femur bone, which is this bone here, slips forward off of the shin bone, which is the tibia bone here. So repairing this thing has to be done to get you back on the field. And this ACL repair, that's exactly what it does. Unfortunately, it only gets professional athletes back for a year, a season or two on average after this is done. What's the problem with this? Well, we've discovered, or we think we've discovered the problem with it. It's because the angle of the repair does not duplicate the angle of the native ligament. The repair ligament has to go in at a much steeper angle than the native ligament, which was much shallower. And we think this new angle of the repair is what creates a rotational instability, which destroys the knee over time. This is illustrated in a New York Times article published in 2017, and it was an article that quoted a Dr. Coker as saying 50% of patients who have the ACL repair will develop knee osteoarthritis within 10 years. Now, that's a problem, because the article was saying that ACL repair rates in adolescent athletes was soaring. It had increased 5 times from 2004 to 2017. So in other words, if you do this repair in a 15 or 16-year-old athlete, 10 years later, they're 25 or 26. Their knee is shot. What are we going to do for them? Not much. The article ended with a question: will surgical techniques that more closely resemble native anatomy reduce the risk? And the answer to that is an unhesitant yes, of course it will. And that's why there is a new procedure in orthopedics now called the Bear procedure. I don't have time to talk about it. You want to talk about it? Come on in, we'll talk about it. What's wrong with the current algorithm? Joint replacement. Joint replacement, quite simply, particularly in the knees, it's just not what it's cracked up to be. And the studies in the scientific literature reflect that. there is minimal functional improvement. Harding did a study in 2014 that showed only 1 out of 20, 5%, achieved normal activity levels after knee replacement. Metzner in 2014 also published a study showing that patients after this procedure still have pain. Some had more pain after the procedure than they did going into the procedure. The average pain level was 5 out of 10 in intensity after a knee replacement. That's considerable pain. And finally, you've got the risk of wear particles. The metal fragments over time. It gets into the tissues. It's toxic to the tissues and causes granuloma formation. And the end result is a lot of pain. What's wrong with the current algorithm? Spinal fusion. Spinal fusion. This is a procedure that is done routinely today for back pain. It is quite simply barbaric. In my mind, it should not be done for back pain. If you are thrown from a motor vehicle at 80 miles an hour and your spine is crushed and unstable, yes, your spine has to be fused. It has to be reconstructed and fused, no doubt about it. But when you start fusing spinal segments because of back pain, what you are doing is destroying the spine. Very simply. A motion segment in the spine is 2 vertebrae and the disc that connects them. That's called a motion segment. Each vertebrae is supposed to move independently of each other. If you do something as pictured here, where you're putting screws and connecting those screws with rods and destroying 1, 2, 3 motion segments here, what you're doing is you're throwing tremendous forces above this construct and below this construct. And what happens is something called transitional syndrome, where the level above and the level below breaks down, becomes painful. And guess what? This leads to the saying in medicine that spinal fusion leads to more spinal fusion. You go back to the surgeon, you say, it's killing me. He goes, up, we got to extend that fusion up, next level. Or, we have to extend that fusion down to the next level. Plus the fact that the literature estimates that spinal fusion fails to solve spine pain in an estimated minimum of 20% of patients. Now, that's a minimum. As a guy who's been trained in spine and has treated spines for 20 years, I would say that spinal fusion causes pain in people closer to 50% of them after spinal fusion. Now, it may work for a short period of time, 6 months, maybe a year, but after that, the pain is back in a big way. So, what is the promise of interventional orthopedics? Well, the promise is that in interventional orthopedics, we use the body's ability to heal itself. What we're doing is we're harvesting repair hormones, repair cells in our patients. We are concentrating them, and then we are focusedly putting them back at a site of injury, sites with poor blood supply. It's minimally invasive. All this is needles across the skin. The word for that is percutaneous. Cutaneous is skin. Per means through. Percutaneous, through the skin. What this does is it reduces or eliminates operative trauma. It results in minimal to no post-procedure recovery and a much less painful rehab. And when we are successful, what we have done is we have preserved native tissues. We have not had to alter or replicate nature's design. Again, as good as we are as doctors and surgeons, when we try to replicate nature, we're always going to come up short. That's my opinion. Here's a schematic of the healthy balancing act inside any joint in the body. And I'm talking about joints in your neck, joints in your back, your hip, your knee, your shoulder, your elbow, your wrist, your thumb. Just like bone, cartilage in a joint is constantly being broken down and built back up. And as long as there is a healthy balance between them, you don't notice a thing and you don't have any symptoms. There are forces that destroy cartilage, bone, and bone. There are forces that repair cartilage and bone. As long as they are in balance, there is no problem. The forces that destroy a joint, break it down, are called catabolic. That catabolic is a fancy word for breakdown. Catabolic forces. And then there are forces that tend to chronic inflammation. And chronic inflammation is terrible for any joint and terrible for living things in general. So, what are some of the things and activities in life that lead to increase of the factors that destroy a joint? Well, one thing is injury. Injury. And remember, surgery is a form of injury. It's a form of controlled injury, but it's a form of injury. And injuries often lead to instability, and instability, without a doubt, leads to, over time, the destruction of any joint. Obesity. What does obesity do? Well, especially in the joints of the lower body, it increases loading forces. And when you increase loading forces in the joints over time, you're accelerating degeneration of that joint. Smoking. Add to the bad things, the many, many, many bad things smoking does. The oxygen radicals that smoking creates in the body just tear up cartilage, tears it up. Poor diets, poor fitness levels, sedentary lifestyle, all of these will contribute to increasing the factors that break down a joint and contribute to chronic inflammation and tip that joint over into a painful joint. So how do we counter these things? Well, there are anti-breakdown factors known as anti-catabolic factors. And what are they? Well, these are chemicals that counteract the pro-inflammatory environment and that counteract the enzymes known as matrix metalloproteinases, MMPs, and peptidases that are digesting the joint cartilage. These chemicals, some of which are known as interleukin receptor antagonist protein, we call it IRAP. And this is a substance that binds a very pro-inflammatory mediator known as IL-1 and neutralizes it. So it'll stop inflammation. Other chemicals inhibit these enzymes that tear up cartilage. These are known as alpha-2 macroglobulin and tissue inhibitor of metalloproteinases, TIMP. Where do we get these? Well, guess what? They're all found in human blood. We did not know that these chemicals existed 15 years ago. We've only recently discovered them. And this is why injecting some blood into a painful joint can be very, very helpful. Other forces are anabolic. What are anabolic forces? These are forces that build up a joint. In essence, what are we talking about? We're talking about growth hormone. And no, we're not talking about anabolic steroids, which is what creates a physique like this. Nothing else will create a physique like this. You got to be on anabolic steroids. We're talking growth hormones, and these are natural substances produced in the human body. They are powerful cell signaling molecules. They promote cell division, growth, and cell health. They increase the formation of new blood vessels. They stimulate the formation and production of protein and matrix secretion from cells. Some of these are known as PDGF. This is platelet-derived growth factor. FGF is fibroblast growth factor. VEGF, vascular endothelial growth factor. These are just a few of the many hundreds of growth factors in the human body. Now, where do we get these? Well, we get these from our patients. These are our patients' repair cells. We call them autologous repair tissues. Autologous, that's that fancy word for self again. What we're doing as docs is we are manipulating these repair cells for use in musculoskeletal injury, joint injury, and arthritis. There are two forms of repair cells in the human body. There is a small circulating blood cell known as a platelet, and you may have heard of platelet-rich plasma. That's where we concentrate the platelets in your blood, and we have something called PRP, and we're injecting that. The other repair cell, much more powerful, is known as an adult stem cell. We get this from your bone marrow in my world. We can get it from adipose tissue, but that's another long discussion. And if you want to have that, again, come see me. And we're happy to talk about it. These repair cells are known as orthobiologics, and that's a conflation of the use of a patient's biological repair cells to treat orthopedic conditions. Orthobiologics, that's what we're talking about here. All right, so let's go back to the healthy balancing act inside of a joint. You walk into my office and I look at your x-rays and listen to your story and examine your knee, let's say, and I think, oh, I can solve this with a PRP injection. And you agree, and we do a PRP injection. What do we get with the PRP injection? Well, we get a ton of anti-catabolic factors, alpha-2 macroglobulin, IRAP, TGF-beta, TIMP, tissue inhibitor of metalloproteinase. Plus, we get a few very powerful growth hormones, notably platelet-derived growth factor. And this can solve many, many issues in a painful joint. But let's say you have worse arthritis than, say, a healthy, active 50-year-old. Say you're a healthy, active 65-year-old and your arthritis is worse. I may say, well, you know what? This is a stem cell procedure. And we do a stem cell procedure, MSC, mesenchymal stem cells. And we get these from your bone marrow. What do we get with that? We get a ton of powerful growth factors, a ton of them. And what we're doing by doing this is we're putting our finger on the scale of this balancing act, and we are increasing anabolic forces that build up the joint and anti-catabolic forces which prevent the breakdown of that joint. And we are tipping this joint, hopefully, back to a non-symptomatic, healthy joint. Let's go back to the algorithm. Let's discuss what happens in my office. You go through all of this preamble, and you get to the MRI. Well, if you're standing in my office, this is what happens. I look at the MRI and I go, oh, I see. You've got a sprain in your medial collateral ligament in that knee, and you've got some softening of the cartilage. Well, you know what? You're a good candidate for a platelet injection into that knee. And so we do a regenerative orthobiologic injection. At about 2 weeks later, I send you back to physical therapy. You work in physical therapy. And when this works out, you come back in 6 to 8 weeks and you go, hey, you know what? That knee is so much better. I am so impressed. Thank you very much, Doc. And what we have done is we have solved the problem, at the same time preserved the native tissue and the native joint. We haven't disturbed it at all. But in a larger sense, look what we have done. We have taken you out of the algorithm that pushes you towards joint replacement, taken you right out of it. We've taken a left turn. And this is where we've ended up. That's the promise of interventional orthopedics. So what we're doing is we're precise image-guided stem cell and platelet procedures to treat. This is what we treat. We treat all this stuff. Shoulder arthritis, rotator cuff tears, shoulder labral tears, wrist and thumb arthritis, elbow arthritis, low back pain, sciatica, facet syndrome, disc protrusions, bulges, hip arthritis and hip labral tears, knee arthritis, knee meniscal tears, ACL tears, ankle arthritis, ligaments and tendon tears. Here are some examples of interventional orthopedics. This is a picture of a procedure suite. It's not mine, but mine looks exactly like this. This contraption is a C-arm. It's a big C. And what it is a real-time X-ray machine. It's throwing a beam from here to a receiver here. And what this is a very surgically draped knee. And this is the picture up here that this fluoroscope is taking. And this is a trocar, an 18-gauge trocar that has been burrowed into the kneecap. This is a needle that has been placed behind the kneecap, and this dark stuff is injectate being injected behind the kneecap. Why? Well, this is the MRI cross-sectional view of the same knee. This is the kneecap. It has this white star in it. Well, that's a bone lesion. That's painful. Why? Because this cartilage behind the kneecap is breaking up, and it's allowing some joint fluid to get into the bone, and it's killing the bone. That's why we've had to go into the bone and inject stem cells. Here, we've lost cartilage over the femur, and that's why we're injecting behind the kneecap. But this is the type of meticulous and focused work that we're doing. This is the injection of a shoulder. This is a labral tear. The first placement of the needle is into the labrum. This little triangle of dark stuff is dye that we're injecting into the labrum and is, of course, going to be followed by the injection of repair cells. The second placement of the needle is into the glenohumeral joint. I'm sorry, I was being technical. And that is otherwise known as the shoulder joint, okay? This next slide shows the meticulousness of this work, okay? This is the median nerve seen in cross-section under ultrasound. And This is a needle coming, hydrodissecting it with platelets, all right? Hydrodissection means you're injecting and you're separating the nerve from the surrounding tissues. For scale, this is the size of a pea, a green pea. So it shows you how delicate this work can be, okay? Why will interventional orthopedics replace elective orthopedic surgery eventually? Well, first of all, it's less invasive. Second of all, there's a quicker recovery time with much less risk involved overall in the procedure. And the final result is we're not taking anything out, we're not putting anything in, we're certainly not putting in screws and plates. We are preserving native tissues. Let's take a brief pause here. Oh, yeah, okay, so we're about 30 minutes in. Uh, this is a bathroom break, a get something to drink break, and while we're taking it, this is how you contact me. I don't have a whole lot more to go. What I want to discuss next, who's a good candidate for this, and then we're going to finish by looking at the literature that shows how this works. Orthobiologic treatment first steps. Okay, just a quick, what do you expect when you come into my office? It begins with an evaluation. You want to bring a friend or a recording device. So, because we're going to cover a lot of information. And most importantly, you want to bring your films, whatever's bugging you, your neck, your back, your knee, your shoulder, your hip, your ankle, your wrist. Because the most important first step is to get a diagnosis, to get the best diagnosis as possible. Okay, here's an x-ray. This is a normal hip. This hip is destroyed. You have to ask yourself as a doc, well, why this hip and not this hip? And the history often gives you a clue. Oh, right. Well, when I was 10, doc, I fell off the top of a 6-foot fence and I landed awkwardly and I couldn't walk right for about a week and a half. Ah, well, that'll do it. Or, I had a labral tear and it was repaired not very well. I had pain afterward for years and years and years. And so that's a clue as to why this joint has failed and not this joint. At any rate, we need to get the best diagnosis as possible for you. Are you a good candidate? Who knows? How do we know if you're a good candidate? Well, luckily, we're blessed by a very large registry of data, and this is patient-reported data, and it's owned by Regenix, and it numbers tens of thousands of patients after these procedures, and it tells us who's a good candidate and who's not a good candidate, for the most part. At least it gives us guidelines. And this data is now robust. As I said, it numbers many tens of thousands of patients, and it follows these patients annually. So the data is constantly being updated, as it were. Let's talk about knees. Who's a good knee candidate? Well, what we can tell you is that there doesn't seem to be any correlation with age. There's no correlation with radiographic severity. In other words, if the knee looks terrible on an x-ray, that doesn't automatically preclude you from success with these treatments. There's no correlation with sex. In other words, men don't do better than women or vice versa with these procedures. And ultimately, there's no correlation with bone marrow, with body mass index or obesity. In other words, how much you weigh. So, yeah, all people can benefit within certain other guidelines. Who's not a good knee candidate? Well, if you have two bad knees instead of just one, that's typically a marker of uh, lower success rate. Let's put it that way. If you are riddled with arthritis, in other words, you have or you have three or more joints that are impacted, like both knees and your hip or both shoulders and your knee, that usually is indicative of a chronic pro-inflammatory syndrome within the body, like diabetes, rheumatoid arthritis. And these are negative prognostic indicators for success, for sure. If you had three or more surgeries on the joint that you're complaining about, that's a bad sign because typically that means the joint is unstable beyond the point of repair. Or if there's a gross malalignment of the knee, as is illustrated here, as you see, the femur bone is literally sliding off of the shin bone, the tibia. You're not a good candidate. You come in and your x-ray looks like this. I tell you, quite honestly, you need a joint replacement. I can't help you save your money. Let's talk about the literature. What does the literature say in terms of specifically for this study, bone marrow treatment. This is an eye-opening study. It was done in 2021. It came out in the late summer. It was done by a French orthopedic surgeon named Ernegow. He treated 140 patients with similar bilateral knee osteoarthritis. What did he do? He injected one knee with the patient's own stem cells. The other knee he replaced. And then he followed them for 15 years. This is an unheard of study, folks. If you don't read the medical literature, and I'm sure most of you don't, nobody does studies like this. This can only be done in a country where the national government supports studies like this. This is a wildly expensive study. It takes time and dedication to perform. 15 years later, what do you think he found? The failure rate in the knee treated with bone marrow compared to the failure rate of the knee treated with a prosthesis, a total joint replacement, was exactly the same. What does failure in a bone marrow injected knee mean? Well, it means over time, eventually you decide, you know what, I got to have the joint replaced, and you have it replaced. Less than 1.2% per year, it was the rate of failure compared to the rate of failure in a total joint replacement. What does failure look like there? It's when you come back in and the doc says to you, oh my gosh, we have to revise. We have to take out the first knee replacement and put in a second one. Well, the incidence there was 1% annually. They're the same. They're exactly the same. Conclusion was this study showed that orthobiologic injection using stem cells had a sufficient effect on pain to postpone or avoid the total knee replacement in the contralateral joint of the patients with bilateral knee osteoarthritis. This is a randomized clinical trial, randomized controlled trial, an RCT. This is the highest level of evidence we have in medicine today. This study came out 4 years ago. A corollary to that study was, what's better to postpone total knee replacement at 15 years post-treatment? Injecting the patient's stem cells into the joint or into the bone as well? That's IO. IA stands for intra-articular. IO stands for intraosseous, into the bone. This was Ernegow. Again, 60 patients with the same grade bilateral knee osteoarthritis. One knee was injected with bone marrow into the joint, intra-articular only. That was it. The other knee, he injected stem cells into the subchondral bone. That's the bone beneath the chondra. The chondra is the cartilage. This was the intraosseous group. And he followed these people for 15 years. What do you think he found? In the intra-articular knees, and that's where you just took bone marrow and just injected it into the knee, just into the joint cavity itself, the rate of total knee replacement was 5% a year. So that over 15 years, 70% of the knees treated like this were replaced. As opposed to those knees that also got subchondral injection of stem cells into the bone beneath the cartilage of the knee. The rate of total knee replacement was 1% per year. Over 15 years, only 20% of those knees had to be replaced. 20 out of every 100. 2 out of every 10. The conclusion, implantation of stem cells in the subchondral bone of an osteoarthritic knee is more effective to postpone total joint replacement than injection of the same stem cells intra-articular dose into the contralateral knee with the same grade of osteoarthritis. The point being, we learned then and there that what you do is you've got to do what we call bone augmentation. You got to inject the subchondral bone with the stem cells. And that's what we do in my office to give you the best chance to avoid joint replacement. Let's talk about hips. Who's a good candidate for this treatment in the hip? Well, in general, what we discovered is that hips just don't do as well as other joints. The shoulder does much better, the wrist, the knee, the ankle. Joints in your neck and back do better than hip joints do. And we're not really sure why that is. But what it does is it gives us very strict candidacy grades. Who's a good candidate? Well, if you're under 55 and you have very mild osteoarthritis, uh, or just in general at any age, minimal osteoarthritis with a torn labrum, for example, you're a good candidate. If you're over the age of 55 and your osteoarthritis is a little bit worse, say moderate, you're fair. If you're a poor candidate, that's defined as being over the age of 55 or any loss of motion in the joint. So that's a pretty strict criteria. And I got to say, at least once a week in my practice, somebody comes in with a badly destroyed, very badly arthritic hip with loss of motion, and I have to tell them, this is not going to work for you. This is not going to work for you. You need to have that joint replaced. And I have had people come back and thank me, having gone on to joint replacement, and they come back for other joints after that because they appreciate the expert opinion, which is what I pride myself on. If you come to my office, you're paying for my expertise in this field. If I think you're a good candidate, I am of course going to try and help you. If I don't think you're a good candidate, I will tell you so. Here's a study on hips. PRP versus hyaluronic acid in hip arthritis. Hyaluronic acid is the gel shot you may have heard about. Gel shots are what are used in orthopedic offices in addition to steroids. In the long run, they really don't work. But this is a study that took 105 patients. It was a good study. It was done in 2022 by Nouri. They took 105 patients and they randomized them to three different groups. One group with a painful hip just got a PRP injection alone. That was it. The second group got just hyaluronic acid, the gel shot into the hip alone. That's it. The third group got both, got PRP and hyaluronic acid into the hip joint. Each group got 2 injections 2 weeks apart. The outcomes were measured at 2 and 6 months after the second injection. And this is what they found. The PRP, the hips injected with PRP and the hips injection with PRP and hyaluronic acid did significantly better than hyaluronic acid alone. The folks who got hyaluronic acid did okay up to about 2 months, and then the effect wore off. At 6 months, they weren't getting any relief at all. So the PRP lasted longer. Again, the study only lasted 6 months, and they got better relief. And most importantly, there was no difference between the two groups that did better. In other words, the group that got PRP was no better or no worse than the group that got PRP and hyaluronic acid. The point being that hyaluronic acid didn't add anything to the PRP response. Okay, here's a picture of a hip injection under ultrasound. This is the needle going in under the transducer. Here's the ultrasound picture. Here's the needle coming down, and this is the joint down here. I know this is all pattern recognition. I know it looks like nothing to most civilians, but to docs who know, it says a lot. Here's another picture of the injection of a shoulder joint. This is a ultrasound transducer. This is the needle going in under that transducer, and you can see the needle and exactly where it's going into what tissue you're injecting. And this is a bursa that's being injected. Beneath the bursa is the rotator cuff. And this is to illustrate our discussion of shoulder candidacy grades. The registry data indicates that there's no correlation between outcomes and age, sex, or obesity. Severe osteoarthritis does well if most of the pain and debility is coming from the rotator cuff, which are the tendons of the muscles of the joint itself. That's a technical discussion. Come into my office. I'm happy to explain it a little bit further. Further candidacy grades in the rotator cuff. You're a good candidate if it's a full thickness tear, non-retracted. In other words, it's torn, but the two parts are not separated more than, say, a centimeter. You're a good candidate. And partial thickness tears do very well with this type of work. It's only fair, you're only a fair candidate if there is a full thickness tear in the tendon and it's 2 to 10 millimeters retracted. That's a fair candidate. A poor candidate is a full thickness tear with retraction greater than a centimeter. Again, we're not going to get any repair on your rotator cuff if that's the case. And here's a picture of an intact of a torn rather rotator cuff. You see the rotator cuff coming over, and all of a sudden there's this big empty space, and then a stub of the the remnant end attaching to the bone. This is a large tear. And this is an exception to the rule. This one was treated with bone marrow, and you can see here that there is now a continuous tendon. That's an exception to the rule. There are exceptions to all rules. This is a rare exception to the rule that if you have a full thickness tear retracted more than a centimeter, you really should have it surgically repaired. This is osteoarthritis in the shoulder, candidacy grades. You're a good candidate if it's mild to moderate, moderately severe osteoarthritis. You're a fair candidate if it's severe osteoarthritis, if the pain may or may not be mostly from the rotator cuff. And you're a poor candidate if it's severe OA with change in the shape of the ball of the joint and a large beard osteophyte coming off of the ball. Here's the ball, and if you look closely, you can see faintly a large osteophyte drooping down like a teardrop. That's what we call a beard osteophyte. You have one of those, you're pretty much a poor candidate for this kind of work. Here's a study done in 2023 comparing platelet-rich plasma, PRP, versus surgery, rotator cuff repair, for partial rotator cuff tears. This was the study subjects. There were about 50 subjects between the ages of 15 and 80 years old. They all had high-grade tears. That was greater than 6 millimeters. In other words, more than half a centimeter. So these are significant tears. They're not full thickness tears, but they're significant tears, and they're causing pain. And these patients all failed, ibuprofen, physical therapy, and cortisone injections into the shoulder. What they did is they randomized 25 of them to get a PRP shot and 20 of them to go to surgical repair, and they followed them for 2 years. And the outcome measures they used was the American Shoulder and Elbow Society Index, and time to recovery, return to work, contact sports. Time to recovery meant when did they return to work and or contact sports. And this is what the study showed. It was a good study. Well done. A highest level of evidence. Basically showed no difference between the improvement. And both groups improved very well. And the percentage improvement was almost exactly the same. 44% in the surgery group, 42% in the PRP group. The mean time to recovery, this is significantly different. 4.6 months compared to 3.1 months. So this study showed, very well done study, showed that PRP was just as good as surgical repair. And at the same time, they were back to playing sports much quicker than in the surgery group. Lumbar degenerative disc disease. Who's a good candidate? Well, if you have severe degenerative disc disease without severe stenosis and up to a grade 1 spondylolisthesis, that's where one bone is slipped forward on the other, is shown right here in this X-ray. You can see coming down the back that the bones don't line up. That's called spondylolisthesis. You're a good candidate if you have those two criteria and they're not worse than that. You're a poor candidate if you have severe degenerative joint disease with greater than 50% loss of disc height and or a patient cannot stand greater than 10 to 15 minutes or severe spondylolisthesis, in other words, greater than a grade 1. You're a poor candidate for what we do. Lumbar discogenic pain. Can't sit for more than 15 to 30 minutes. That's the hallmark of discogenic pain. If you have preserved disc heights with a tear in the annulus, as seen here, this is a dark disc, as you see, but it's about the same height as this disc, but it's got this white area in the back. That's an annular tear. This is a good candidate for what we do. You're a fair candidate if you have lost about 50 to 75% of your disc height with a tear in the annulus. Okay, here we got a tear in the annulus, and this disc is thinned out compared to this disc, but not dramatically so. You're still a fair candidate for what we do. You're a poor candidate if you have more than 50% loss of disc height with a tear in the annulus. It's just not going to work. Disc protrusion with leg pain. You're a good candidate for what we do. This is a disc protrusion here, pushing back in the central canal, slamming the L5 nerve. This is it in cross-section. That shows you the size of that disc protrusion, hitting a nerve, causing terrible sciatic leg pain on the right. This is a patient with this type of symptom, a good candidate for what we do. You're only a fair candidate if this protrusion is subligamentous. In other words, it's beneath the posterior longitudinal ligament. or rather, this is the anterior longitudinal ligament, but you see the disc is contained beneath it. That means when we inject here, the injectate is really not getting to the disc. So we only have a fair chance of success. You're a poor candidate if that disc is what we call a hard disc. It's calcified, it's associated with a bony ridge. In other words, it's causing a intrusion into the central canal where there are nerves, and it's a hard disc and it's not going to go away. It's a fact on the ground. That means you're a poor candidate for what we do. What does the literature say? This is a systematic review done in 2023. They looked at 13 randomized controlled trials, RCTs, the highest level of evidence we have, evaluating a total of 914 patients. 7 studies looked at intradiscal treatments, people with discogenic lumbar back pain. 3 studies looked at people with disc protrusions and leg pain, epidural injections of platelets. 2 looked at facet joint injections. These were PRP and stem cell injections into the joints of the spine, of the neck and back. And 1 looked at injection of ligaments and muscles, 30 patients. The conclusion was that PRP was, in general, a safe and effective treatment for degenerative low back pain. The level of bias in the studies was low, and this was thought to have represented level 2 evidence, not the highest, but the next highest. In other words, moderate evidence in favor from multiple relevant trials. The 30,000-foot view. We're able to help many patients with severe arthritis avoid a knee replacement. And this doesn't work by growing you a new knee. It works by making the toxic chemical environment in your knee healthier, making the knee stabler, and putting up a huge roadblock to the further degeneration and progression of arthritis in a joint. We can treat mild arthritis and prevent it from getting worse. We can treat meniscal tears in the knee. We can treat ACL tears in the knee. We're able to help many patients with severe shoulder arthritis avoid a joint replacement. Remember, as long as the majority of the pain is coming from the rotator cuff, and we can repair rotator cuff tears without surgery, and we can repair shoulder labral tears as well. Finally, we're able to help many patients with chronic back and leg pain and other knee or joint ligament tears. I think that's about enough. I've talked for nearly an hour. We are going to progress rapidly to the end. Well, that was a long time. I hope I didn't bore you. We covered a lot of ground there. I'm sorry that it was longer than I anticipated, but you've had a fairly thorough medical lecture on what this field is all about and how it should be done, and really kind of what you need to avoid if you have a similar type of pains in your joints, neck, or back. Hal has a question. Will there be a video available after the presentation? You bet there will. Just contact my office and Patty will send you a link and you can look at it as many times as you like. Grace has a question. Is someone with PTTD a candidate? Post-traumatic PTTD, post-traumatic. Oh boy, I'm sorry. The acronym is not, Grace, it's not reading for me. I'm not sure exactly. Can you retype your question? Tell me what PTTD means and what pain is it that you're having? I'm happy to answer the question. Post-traumatic, I don't know, not coming to me. Sorry. Hal had another question. How long to wait for an appointment with you? I don't think anybody's waiting. Call the office. Patty's very pleasant. If you're in a rush, I'm sure she can work you in. Larry has a question. Is PRP covered by Medicare? No. PRP is not covered by any insurance, Larry, and that's one of the drawbacks of PRP. The way we work in my office is I'm happy to see you and evaluate you under your Medicare insurance. I am happy to treat you like any orthopedic in the country would treat you under your Medicare insurance. The minute we get to the point where I feel that you're at a crossroads, and you have to choose between going to surgery or doing what I can do for you, that's the point where I send you a proposal and tell you, well, your insurance is not going to cover this. This is what it's going to cost you. That's the way it works in my office. But no, there's no insurance anywhere that covers PRP injections. Um, let's see, who else? Patricia has a question. Does anyone assist during the procedure? No, no, no. All procedures are done entirely by me. I have my faithful assistant, Lynn, and Lynn just helps me with the fluoroscope. She prepares the skin, drapes the skin. She prepares the surgical trays that I'm using, the sterile trays I'm using. But the procedure itself, no, no, it's all done by me. Mark has a question. PPPD. Mark's trying to help me with this, with Grace's question. PPPD, persistent postural perceptual dizziness. Wow. Wow. I'm not even sure I know what that is. I think you're probably talking about cervical cranial instability, Mark. Yeah, we treat that routinely in my office. Grace has clarified, posterior tibial tendon dysfunction. Yes. Yes, Grace, we treat that. I'm sorry. I just didn't pick up the acronym. Yes, yes, we treat. I just the other day was doing a medial ankle and was treating. This was in a semi-professional bicyclist and had chronic medial pain, and I think a lot of it was coming from PTTD. And we treated the posterior tibial tendon. Actually, we were treating it for the second time. He got a lot of relief the first time. We did it again the second time. So, long story short, yeah, we routinely inject the posterior tibial tendon. Um, Hi, Mark. PPPD seems very similar to POTS. Yes, yes, I would agree. Grace, no, that's not it. I'm sorry. Posterior tibial tendon dysfunction. What's not it, Grace? Oh, oh, I see. Larry had another question. What is the cost of consultation? Larry, I will see you under your insurance. So whatever your copay is under your insurance, I'm happy to see you under your copay. If you don't have insurance, typically we charge $300 for an initial evaluation. But if you have insurance, come on in. We accept it, and we'll see you under your insurance. Marley's had a question. How is the PRP created? Uh, uh, we get PRP from our patients, of course. And how that's done is we cannulate a vein in your arm, just like when your private medical doctor orders a blood test and you go to Quest and they stick a needle in your vein and get some blood. That's exactly how we do it. We get maybe a little more blood than Quest will take. And then we trot it down the hall to my laboratory and we process it. And by that, I mean we separate the elements of the blood and we take out the platelets and we concentrate those a little bit further. And depending on what I'm doing, I may use one form of your platelets versus another, meaning I may put your platelets through a rapid freeze and thaw cycle. And what that does is it destroys the cell membrane of these tiny little cells. And what I'm left with is a soup of the contents of your platelets. And that I will use for certain applications. If I don't use that, I will use whole platelets, platelet-rich plasma, and inject whatever we're injecting. So yeah, that's how we get that's how PRP is created. We're basically just taking it from you, separating it from the other blood elements and concentrating it down and then putting it back in a very concentrated form into the areas that need it. Yes. Anonymous attendee, where are you located? I am located in Norwalk, Connecticut, 06855, precisely at 91 East Avenue in Norwalk. Patricia, looking forward to getting. Yes, I'm looking forward to seeing you, Patricia. Larry had another question. I have knee x-ray. Will I also need MRIs prior to the consult? It will be helpful, but it's not strictly necessary. If you need one, I'll order it for you if you don't have one. I also can take an x-ray, and if your x-ray is old or it's not clear enough, I'll take another x-ray while I'm evaluating you. So that's not a prerequisite. That fast tracks things. If you come in with an MRI, I can tell you right then and there after I examine you, A, whether you're a good candidate, B, what exactly I want to do, and then send you a proposal, which you'll have within hours. So it fast tracks things, but it doesn't preclude you coming in, telling me your story, letting me examine the knee, look at your x-ray, and then probably say to you, yeah, let's get the MRI. Marlis had another question. What is the time frame from where you draw the blood to the PRP injection, and can I bring an MRI disc? Of course, you can bring an MRI disc. Of course, you can. That's very, very helpful. And if you have one, absolutely bring it. What is the time frame? It takes us 10 minutes to draw your blood. It takes us anywhere from 40 to 60 minutes to concentrate all those platelets that we get from you in the laboratory down the hall. Then, depending on what we do, what we're doing, um, it could take the better part of an hour to put back into you to, inject you. You have to get out of your head that this is a single injection. That's not the way this is done. If you come in and the inside of your knee is bothering you, and I have an MRI and I look at your knee with ultrasound and I see that you've got a sprain of the medial collateral ligament, that you've got an extrusion of the medial meniscus, and the MRI shows that that meniscus is a little torn, and you have the beginnings of some arthritis. Well, this is what I'm going to have to do. I'm going to have to inject the medial collateral ligament along its length entirely. I'm going to have to inject the medial meniscus, right where the tear is. I'm going to have to get into that tear and inject that tear. I'm going to have to inject what we call the medial compartment of the knee. And then, depending on how bad the cartilage is lost, I may have to go into the subchondral bone beneath that cartilage loss. So, it's not just a single injection, boom, there you're done. People who do it that way are not doing it correctly. That's another thing that we didn't get into tonight because I was talking forever. There's a lot of fraud here. There's a lot of very poor training. There's a lot of people doing this because it is a cash on the barrelhead procedure. Insurances don't cover it. They have no training in doing it. All they do is sign up for a weekend course on how to use a centrifuge. So that they can isolate platelets via the use of a kit that they buy from a vendor, get some PRP, and then have a nurse practitioner inject it into a joint and say, there, you've had a PRP injection. It's not the way it's done. I'm sorry I went on and on there, Mars. I hope that answered your question. Anonymous has another question. After stem cells have been extracted from the bone, does your body regenerate them? Of course it does. Your body begins to regenerate blood and stem cells the minute you take it out of the body. In fact, your body's generating these cells all the time. So if we take out a fair number, your body just steps up the production of them. Yes, your body replaces all of this. What kind of pain can be expected with injections? Anything to numb or relax? Yes, yes. We give you a cocktail to relax you on the table. Absolutely. And what we're using are called anesthetic grade needles, meaning that they're very, very thin, very, very tiny. They're just stiff enough to do the job, say 2 or 3 inches beneath the skin. Do they hurt when you put them to the skin? Sure, they do, but it's just like a sharp needle poke. And it's not that big a deal. Often this pain is amplified by people's anxiety about what's happening, and this is where the cocktail that we give you comes in. It relaxes you. We also use some local numbing cream, and if I'm going in with a larger than anesthetic grade needle, of course I numb the skin. Yes. So between all of these things, this is how we get everybody through these procedures. They're not particularly painful. Some are more painful than others. It's usually after the injection where there's real pain, particularly in very reactive joints like the shoulder joint. Notoriously reactive, can be quite painful in the first few hours after injecting stem cells or PRP into it. Yes, Grace, we give you Xanax type drug. We use Valium. We use promethazine, and we give you some post-procedure pain medicines, which you are invited to take before the procedure as well, if you're very concerned about it. Again, these are just needle procedures. No, they don't hurt like stink. Let me take that back. Bone augmentation can hurt like stink. Yeah, it can for a few seconds while we're injecting the bone. That's why we always do bone augmentation last when we're doing it. But that's a technical explanation, which I give to you if that's what we're going to have to do in you. Um, Everybody gets through the procedures. Um, but I know there's always a great concern with what the pain is going to be. But almost always people say, "Oh, gee, that wasn't as bad as I thought it was going to be," and it never is. That's the answer there. The pain is never as bad as you think it's going to be. There's a little pain. Yes, you're gonna feel it. It's not like you're gonna go to sleep, have a nice nap, and wake up and it'll be all done. No, you're gonna feel me poking and you're gonna feel me touching tissues. Once you're beneath the skin, it's not that painful because you don't have pain receptors beneath the skin, or very many of them. Any other questions? Let's see here. Michael had a question. Is the treated regenerated ligament as strong as the original? You bet it is. You bet it is. That's the concern with a surgically repaired ligament is over time, we're worried. We assume that over time, even a surgically repaired ligament will remodel itself, but that's not always the case. Um, because they're cutting and sewing, quite often you can get a weakness at exactly the site where they sew. What we're doing here is we're just injecting growth factors into the torn ligament and letting the growth factors bark out orders, and the body repairs it in a biologically fit fashion. So yes, when we're successful, we expect the ligament to be just as strong as the native ligament, native untorn ligament. Any other questions? Again, it's my pleasure and privilege. And I do take pride in serving as your expert if you come into my office. Bring me your films, tell me what's bugging you, let me do an exam, look at your films. I'll give you an expert opinion. Are you a good candidate for this? I'll tell you if you are, I'll tell you if you're not. This is my passion. At my age, I probably should have retired a few years back. I have no intention of retiring. Um, these are hard-earned skills that I've picked up, and I'm happy to share them with my patients who need them. All right, folks, I don't see. Oh, here's another question from Grace. I appreciate the time you've taken. Well, I appreciate you for spending all this long time tonight with me, Grace. Appreciate that very much to all of you. Thank you for coming out on a cold night, as it were, figuratively, and spending time with me. I hope to see you in the office. I look forward to being able to give you an opinion on whatever bugs you. All right, folks, take care. Be safe. Have a good night.